Sachin, just give the co-host rights to me as well.
Yeah, yes, sir, yes, sir.
Yeah, because if I find any executive committee in the waiting list or in the attendees, then I can just quickly upgrade them into panelist.
So do I need to share my slides or they will be shared by the moderating team?
I would suggest you share it by yourself. The reason being, you will have a better control. Otherwise, you'll have to keep saying next.
Next slide, right? So
Okay,
I'll
so
just
it's better that
start.
you do it yourself.
Okay, sir.
Good evening, Tapan sir.
Good evening, Uday. How are you?
It's all good, sir.
Dr. Tapan, good evening. Nice to see you.
Good evening. Velu, how are you?
Very good. Very nice to see you. You're sounding good, my dear.
Yeah.
Very good.
तपन सर गुड इवनिंग
Good evening, Pankaj.
कैसे हैं सर? मैंने आपको मैसेजेस किए बट आई डिड नॉट गेट एनी रिप्लाई फ्रॉम
Oh,
यू.
I'm sorry, I missed it. I don't know. I am physically better, but this post-viral neuralgia is killing me. Whole brain is heavy whole day, 24/7. So much of pain. So
अच्छा, it's still,
this will not go away. It will take time. Damage was so much.
इसमें टाइम लगता है.
No, sir, बहुत टाइम हो गया. It is
साल
more
डेढ़ साल
than.
तो लगेगा अभी.
Yes, sir.
I'm back to work.
अच्छा.
That's a good thing.
That work. I mean, mid of March I came back to work.
Nice.
But ये थोड़ा neuralgia. अभी now I realize that how people suffer from post-herpetic neuralgia.
Yeah.
Especially on the face.
Can be terrible.
Unbelievable. Yeah. And I can't take all those pregabalin, gabapentin.
Yeah.
Those are not for me.
Yeah.
Anyway, I'm fighting.
Good. That's the way to go. That's the way to go.
With all your blessings.
100%.
Right. Good to see you all.
Very nice.
Shaji sir, you are muted.
Oh, yeah. Just entering, Dr. and hope you get better soon. So.
Hi everybody. Hi Shaji. This is Rahul. Hi Uday.
Hey.
Sir, good evening. Sir, आपके नाम महक करके आ रहा है sir.
I have just logged in from that. Hi Velu sir.
Okay.
Hi Rahul. Welcome.
Hi Pankaj sir. Hi Tapan sir.
Hi.
Hi.
Good to hear. That's right. Good to connect.
Yeah.
Rahul Bhaga sir, thanks a lot for everything. So no words.
Thank you. Thanks a lot. Thank you. It's a great initiative. I think people will get benefited out of it.
ये बहुत देर से we were trying, but चलो anyway, I think ये शुरू हो गया. It's a good addition.
Yeah. One minute to go. I think sharp by 5:30 we can start today.
Yes, sir. Sachin, give me a countdown. Good evening, Reena ma'am.
Good evening.
Good evening, Dr. Reena.
Good evening, sir.
Good to hear you, Reena.
Yeah, I thought I've been out for a long time, so let me get back.
Yeah.
I think, sir, we can start now. 5 seconds.
Yeah, sure. Just put on the first slide, please.
Yeah.
Good evening, all. Next slide, please. So good evening to one and all. So today we are scripting a new addition into the history of Indian Myeloma Academic Group, wherein we are going to start off with our monthly program of problem case review and opinion board. So we have aptly labeled it, acronymed it as iProbe. I stands for image, P for problem, and P and R stands for R for the review, O for the opinion, and B for the board. So the probing is to probe for the various, for new learnings, new initiatives, and new way of managing patients. So all of us, when we manage our day-to-day patients, we do have a query in our mind, am I doing it correct? Or something better can be done. So we have started this particular thing, which would be a case-oriented discussion of how to ideally manage our cases. And there's no right or wrong in clinical medicine. It is all what that helps the patient the best. And whenever we are going to discuss cases, we are not going to discuss what went wrong. What we are going to discuss is what better can be done for the patient if the same patient comes back to us again. So with that idea in our mind, so today is the inaugural session for this iProbe, wherein we are going to have this hourly monthly meeting on second Thursday of every month. Fourth Thursday, we are already doing our journal clubs and the journal scan with the quiz. So this would be on the second Thursday from 5:30 to 6:30 p.m. And today is the first meeting wherein the format is going to be that we are going to have two cases which are going to be presented by a presenter, which is going to be Dr. Mehak for the next couple of months, wherein she will present two cases, 5 to 6 minutes each. Thereafter, the national experts and the international experts will decipher the case and will help us in understanding what can be done in an idealistic scenario or in a better way to help the patient. And thereafter, we'll take question and answers from all the attendees who are on board related to the case. But we'll strictly cut it down to 18 minutes as that we have a total of 25 minutes per case. And we do the complete discussion in an hour's time because we understand the value of the time for each and every one of you. So for today's meeting, we are going to have Dr. Rahul Bhargava sir as the national expert, along with Lieutenant General Velu Nair sir, PVSM, AVSM, BSM Bar, who also happens to be the president of IMAGE as the second national expert. And we will have Dr. Shaji Kumar sir from Mayo Clinic, who also happens to be our international executive committee member and one of the founders of IMAGE, to help us with the international expertise and idealistic scenario of how to go about things and put academia along with clinical practice at par. So with that, I would like to hand over the stage without much more ado to Dr. Mehak for presenting our first case. And at the end of the case, I would hand over the stage to General Nair to take on the discussions further. With that, over to you, Mehak.
Right, sir. Hi, good evening to all. I'm Dr. Mehak Trehan. I'm an associate consultant in the Department of Hematology, Hemato-Oncology, and Bone Marrow Transplant at Fortis Memorial Research Institute, Gurugram. It gives me immense pleasure to present the first case of the iProbe series. And one second, we start with this one. Yeah. So before starting, are my slides visible, sir?
Yes.
Yeah. So I've named it as when two bispecifics targets are not enough. My slides. One second, sir.
Ma'am, please click next.
Hold on, it's right. Fine. Okay. Are they moving, right?
Yes.
Yeah. So this is a 62-year-old gentleman who presented to us first in November 2024. Diagnosed with multiple myeloma, translocation 1114, given 4 cycles of Dara-VRd, had more than VGPR response, taken up for transplant in March 2025. Day 100 bone marrow flow cytometry negative MRD, given VR maintenance, and thereafter within 12 months of maintenance relapsed. And what exactly was the course of relapse and what we did, I will be coming to in the next slide. So time points, November 2024, primary diagnosis, Dara-VRd, achieved VGPR, taken up for transplant. March 2026, he presented to us with dyspnea, some bony pains. We did a marrow again. It had 60% clonal plasma cells and M protein of 0.6, kappa of 67, lambda of 10. Repeated the FISH, it had translocation 1114 in 95% of the plasma cells, with del 17p in 70% of the cells, and 1q amplification with IGH rearrangement. So 1114 was persistent and he had acquired certain high-risk abnormalities. Had a discussion with the patient regarding various options available, went ahead with the commercial available bispecific, that is teclistamab, He received 4 weekly doses of teclistamab. After the end of 4 doses, we reassessed the response, and the patient's M band had increased from 0.6 to 1.5 and kappa from 67 to 270. Within 1 to 2 months with teclistamab. So we gave the option to the patient to, let's add another bispecific, that is GPC5RD, versus starting with venetoclax. And the patient said, let's go ahead with talquetamab. Talquetamab, as of now, is not commercially available in the country. It was acquired by imported route. Patient received 4 doses, weekly doses of talquetamab. At the end of 4 doses, the M band was 1.3 with kappa 221 and lambda of 2. And it was a partial kind of a response. And then patient also developed some cytopenias, assessed, had CMV viremia of 94,000 without any end organ damage, was started on IV ganciclovir. Just looking at the trend of the M band at the light chain, so it was 0.6 at the time of relapse. Post teclistamab, it was 1.5, and post talquetamab 4 doses, it was 1.3. If we look at the kappa light free chain ratio, amount, it was 67, increased to 275 post teclistamab, and thereafter reduced to 221 post 4 doses of talquetamab. We decided to go ahead with the genetic testing. So we know that the BCMA, it is encoded by TNFR-SF17. So when we did BCMA mutation testing, the target was intact. There was no alteration in TNFR-SF17. And if we looked at the genetic profile, patient had, along with TP53, which was 58% VAF and 35 respectively, along with certain more mutations of cell cycle checkpoint escape and NFKB activation and ATM gain. So we did check for surface BCMA, but density was not assessed. So currently what the status is, patient has infection with CMV viremia of 94,000, has cytopenias with hemoglobin 8, platelet 34,000, TLC of 3,400, ANC was preserved 2,100, has lytic lesions and 60% marrow disease, not a good objective response to talquetamab. Performance status ECOG PS1. We don't have BCMA CAR-T available in the country. On monthly IVIG and opportunistic infection prophylaxis. And the genetics / the resistance report, as I have shown in the previous slide. So these are the questions for the iPro panel, which I will ask Dr. Velu to discuss and take.
Thank you, Dr. Mehak, for that crisp and brisk presentation. And I would actually, go to the questions. A few housekeeping rules. What we'll do is we'll go to the host institute, which is presenting the cases, for their comments, followed by the panelists, and then we open it on the chat, and then we also have our EC members here. And in half an hour, whatever we can cover, we'll cover. So in the next few minutes, I would request my friend Dr. Rahul Bhargav to give his comments on the planning of the therapeutic approach to this patient, and if he has any ideas how to take it forward. And of course, just a few minutes, and then we can open it to others. Rahul, please.
Thank you, sir. Thank you for this opportunity. I think the only thing where we were concerned with this double hit myeloma with 17p, 1114, and 1q was that combination therapy is better? Would have been sufficient to use teclistamab and talquetamab together, one. In the talquetamab arm also, the daratumumab plus talquetamab plus pomalidomide would have been better in this condition or not? And where is the role of venetoclax to be placed in these settings? So these were the 3 things where we would like to get the help of the panelists and the international expert in knowing that if it is a high-risk condition, would it have been better that we would have given 3 triple drug maintenance to have a prolonged PFS? Now we have an access to BiTE therapies. Would it be beneficial to use BiTEs if we know this patient is upfront high risk, irrespective of the MRD status? So these are the 5 questions which we will dwell upon. Over to Dr. Velu.
Thank you, Dr. Rahul. So with those comments, I would request Colonel Y. Uday to give his comments on the combinations used and the present evidence for the same.
Thank you, sir. So I would go with the first two, that whether this is primary resistance after 4 weekly full weekly doses. So when it is written as 4 full weekly doses, I presume from Dr. Mack that a step-up dosing was given, and these are the 4 weekly doses after the step-up.
Yes,
So with that, yes, this would fit into a primary resistance as far as the thing is concerned. But when we talk about the stop, this is particularly for all others who are on the group. So when we say we should stop the therapy, the ruling is that more than 25% rise in M protein and involved FLC on 2 occasions, 1 week. So just not one testing, we might have to do additional testing just to see that there is a concordance between both the markers, and it is a safeguard against a pseudo progression or steroid withdrawal artifact, which can sometimes occur. Here it was done once, so probably one more report a week apart, or maybe at the 6th week, to say whether the patient had a confirmed progression or not would have been the one thing. Second, if at all, if the patient was in stable disease or MR, I would have continued for another 2 to 3 weeks before saying it. But all said and done, I would agree with stopping the therapy with the type of the disease that the patient had and 60% disease. Now, second, coming to BCMA resistance. So what was done in this patient, we have checked only 2 possible mechanisms out of the 4 mechanisms. And in Indian scenario, actually, there are few loopholes. You know, we do not have all the testing facility, particularly BCMA density is more important than soluble BCMA values. So soluble BCMA does not tell us actually about what is the density on the cells, and soluble BCMA acts more as a sink, far more for the BCMA CAR-T and ADCs than for a bispecific. So a surface density would have been a better solution rather than a soluble BCMA. T-cell fitness is something which in India is extremely cheap. So maybe a CD3 plus absolute count, a CD4 CD8 ratio, naive to memory ratio, or the exhaustive or the senescence markers, which can all easily be done by a flow cytometry, is one thing which I would have definitely done at this stage. And though we do not have, but GPRC5D expression before talquetamab. Now, Professor Mohammad Mohty keeps saying that talquetamab, the BCMA is like a heart, and GPRC5D is like the limbs. So if you keep shooting at the limbs, the person won't die. But a single shot at the heart can kill the person. So giving talquetamab alone is like harming the individual, but not killing it perfectly. So that way, a talquetamab monotherapy is something which might not help in a patient who is already resistant to teclistamab or not responded to teclistamab, because here the failure mode is more mechanistic than target specific thing in this particular scenario. And as Professor and as Rahul Bhargav sir said, here a combination of POM would have been a good partner here in this particular case. And in fact, today morning the NEJM has published DARA PD, DARA TEL, DARA PD, DARA TEL, and talquetamab with DARA. So taking the clue from there, a combination of pomalidomide would have been slightly better in this particular scenario. So that's where I would rest my case and hand it over back to Velu.
Thank you. Thank you, Uday. Thank you very much. I will now go to Professor Shaji. Especially, where do we place venetoclax having a translocation 11-14 in this setting, and complicated by later, findings of a del-17p with a TP53 and a 1q amplification. He has authored the paper on venetoclax, and which is makes very good reading. So I want his comments on 2 things. One is there any role before we go to that, if at all, of ADC? Antibody drug conjugates, we know about it. We also have an early access program in our country now for belantamab. And then, of course, followed by placing venetoclax in this equation as of now. Dr. Shaji, please.
Yeah, it's an interesting case. I mean, clearly it's a functional high risk. This patient, I'm assuming that the fish didn't that he didn't have a 17p deletion and 1q amplification at the baseline. Hopefully was not something that was missed on the fish. But assuming that it was not there, the fact that both came up within a year after transplant at the time of relapse, indicates a genomically very unstable clone, probably highly proliferative, the rate at which it is progressing. We talked a little bit about the mechanisms of resistance. It's very, very uncommon for plasma cells to have BCMA go away completely in terms of expression. Most of the mechanisms of resistance, I think more important to some extent may be the mutations that prevent the binding of one bispecific. And that's the one key thing, the mutations being one mechanism, it looks like, at least from the initial studies, that even when, let's say, teclistamab does not bind to it, it's still possible that elranatamab or linvoseltamab might still bind to that. And to Dr. Nair's point about the ADC, would be, certainly still could be effective. But in this particular setting, without any abnormality being documented, it's highly possible that we are talking about, a T cells not being as functional as it should be. But unfortunately, even though we can look for a variety of different markers, there is no established clinical threshold that would tell us, okay, this patient is not going to respond or is going to respond to a T cell redirection therapy. So clinically not very useful at this point, the whole T cell fitness assessment. Now, this patient clearly progressed very fast through the teclistamab. Now, even though after one cycle of talquetamab, the patient did not reach a PR, the fact when you look at how fast that was going up before he got the talquetamab, and the fact that you're actually starting to see that curve coming down, tells me that it's clearly working to some extent, but by itself is likely to be insufficient. And my choice would be to actually add daratumumab to the combination, and talc-dara would probably be my first choice. Certainly POM could be too. I mean, the TAL3 trial did not look at dara-POM. Talc-POM, it looked at talc-dara-POM. And the addition of POM to talc plus dara really did not add much other than toxicity. So we don't really have a lot of data for the talc plus POM. So talc plus dara would be my choice for this particular patient. And if that patient relapses or once breaks through that, one could certainly consider using belantamab, because it does not really depend as much on the T cell fitness in terms of getting activity. Now, the question about venetoclax is really a difficult one, because what we saw in the Bellini trial is if patients have 1q amplification and 17p, almost nobody responds to venetoclax, even if they are 11-14 positive. Now, whether adding a small dose of venetoclax at 100 milligrams daily to the mix, don't know. The challenge is that the immunosuppression can become quite a bit. Already immunosuppressed quite a bit from the bispecific antibody and the daratumumab if it's used in combination. So, push comes to shove, if you don't have too many options for treatment, it is something worth trying in combination, probably, but I would have very low expectation of the venetoclax really adding a whole lot to the mix.
So Dr. Shaji, we have an unfriendly guest amongst this whole cocktail here. You have CMV over 94,000 copies with a platelet count of 34,000. It sort of complicates what we add to make sure that you keep the myelosuppression at the bare minimum. And how do you also treat CMV at the same time? Because whatever we add is going to be immunosuppressive, thereby promoting multiplication. So where do we strike the balance, and what would you do to the CMV at the same time?
Yeah, no, I mean, it's a challenging spot to be at, but unfortunately, this disease is quite rapidly proliferative. It's coming back so fast. I don't think we have the luxury of not treating the myeloma while treating the other things. So, my option would be to continue with the talc-dara, and then use IV ganciclovir, treat the CMV. Platelets will likely require transfusions. Now, the fundamental challenge here is, how much of the cytopenia is related to drugs, disease, or underlying bone marrow capacity. And the only way to know is by knocking each one out of the equation. So I think if we can control the disease with talc-dara, keep the viremia under control with IV ganciclovir. Of course, the ganciclovir itself is going to cause some cytopenia.
So why don't we choose foscarnet here?
Certainly, I mean, it's certainly reasonable to try either one of those.
Yeah, good.
So the platelets easy to transfuse. So
yes, we'll have to support platelets. hit, as hard as we are allowed to in this setting, and try to, address the cytopenia at the same time, because it's multifactorial here. Disease, drugs, both play a role. From the chat box, there are two questions. One is Dr. Sumit from ACTRAC. The question is an early relapse post autograft a harbinger of a poor T cell fitness? I'll go to Dr. Shaji for this. Is it a surrogate marker, he's saying,
And probably to some extent, I think, there is data suggesting that, inadequate lymphocyte recovery post-autologous stem cell transplant usually predicts for early relapse. So there's probably some component of immune control there, but the majority of the patients who have an early relapse after stem cell transplant is driven by the clone itself, and they generally tend to have some of the high-risk markers, so they tend to acquire high-risk markers, like what this patient has done.
Okay, so the next question is for the presenter herself. Dr. Mehak wants to know, the combination of TEC with TAL, and I think you have the Monumental 6 actually addressing this. The combination of teclistamab with talquetamab.
So right. Dr. Rahul has put that question in the chat box. He's logged in by my name, so that's
Sir. Fine. So he's from the same unit. So we take the question from your unit.
Yeah, so the TEC plus TAL is very effective combination, no question about it. The extramedullary disease and now the TAL6 data that should be coming out soon. If teclistamab, this patient broke right through teclistamab, as if nothing was done, I would not use the combination at this point in time. I don't think there's that kind of a synergy to support the adding the TEC to the TAL. I'd probably use something that the patient has not seen before or seen very limited, like the daratumumab.
Okay. Dr. Tapan has a question. He says, flip the coin. This seems to be heading towards a poor outcome. When would you switch to palliative care?
I think that's a discussion you always have to have with the patient at any point in time, I guess, whenever they are ready for it. I think we still have,
some time before we...
Right. We haven't tried all the things we have access to. So I think it's, if the patient is willing to consider additional therapy, I think we should offer it to them. But at the same time, this is a rather unfortunate situation. And I don't know if we're going to keep this disease under control for very long periods of time, irrespective of whatever we might have in hand.
So here comes, science versus the philosophy of art. If you're financially well off, you can try. You still have something which you haven't tried in your bag, you certainly will go for it. But in our country, we have both the situations where, though we know we have something, but if you're financially sort of exhausted, you also don't have, many options. This becomes a reality. So what Dr. Tapan is asking, we always must discuss, and it comes into play. And depending on what situation you are. I think we have just time for a couple of more questions.
Can I ask?
Yes, Pankaj.
So we don't have the luxury of getting talquetamab. So in some of our patients where the teclistamab is not working, we have done plasmapheresis in one patient, and after that, when we gave teclistamab, the patient went into complete remission. So just want to share that experience and ask Shaji opinion about that.
Yeah, so this has been reported by the German group as well. I think there's certainly the sync effect, and that is probably some of the activity we see with the TEC plus TAL too. We think in the combination, the talquetamab probably not being affected by the BCMA sync effect gives that early tumor activity, and that brings the BCMA levels down, so the teclistamab actually works better. So yes, there are situations, but this patient, I don't know what the levels were. It was like 67 for the light chain, and then the M spike was at 1.3 or 1.5. So yes, significant amount of tumor bulk. I mean, it's certainly something that can be considered.
Yeah. So Dr. Uday, Professor Uday, Colonel Uday, please go ahead.
Sir, so a quick one. Sir, you suggested TAL with DARA. Now, the point is the data from TRIM2 strongly suggests about using it only in patients with intact T cell compartments. So that's the primary phase on which the whole TRIM2 works. So now in this patient, there are enough pointers for a poor T cell function, and has also been brought out by Sumit. So the thing is, in a patient with all this T cell not fucking well, with CMV 94,000, with platelet of 34,000, don't you think that adding TAL with DARA might be slightly difficult to handle?
Don't think so. I think, again, a lot of this the problem with all these immune studies is there is no real threshold that you can use clinically for what is a fit T cell versus not a fit T cell. I think that this T cell, dysfunction across the spectrum, more in some, less in others. The question is, again, you add something to TAL, right? I think POM I would in this patient is clearly refractory to lenalidomide. And I think the incremental benefit of POM over len in that setting is probably going to be limited. This patient did get into a very deep response with the 4 cycles of DARA-based combination. So to me, I think the DARA makes most sense to combine with talquetamab at this point.
Thank you. So last question for this particular case is from Dr. Shilpa Gupta. She says, since it cannot be called a pentarefractory disease, is there any role for Carfil in this case?
Absolutely. I think, this patient, you can certainly use it. Remember that this patient was on bortezomib maintenance when they relapsed. So obviously, there's not super sensitive to PI, but I think if you're thinking about additional therapy lines beyond what we looked at, let's say this patient gets DARA, gets a response, controls the disease for some point in time, then you have other choices down the lane. You can certainly use carfilzomib with cyclophosphamide or carfilzomib with pomalidomide. You can use selinexor combinations. You can use the BCMA ADC. VDT pace, yes, you can control the disease transiently probably, but again, question is what can you do to get some durability of the disease control? But again, it's really tough in this situation. Now that I don't know how long this patient might benefit from the TAL plus DARA, even if you were to go down a CAR-T route, even if it's accessible, I don't know how durable that response would be.
So having given the therapies including BCMA and the GPRC5D, so if we have access to a BCMA CAR-T, what would be your suggestion, or it won't work?
I would be skeptical about it working. I'm just of how fast this patient broke through the whole teclistamab. Again, to Pankaj's point, some of it may have been related to the BCMA levels. Generally, even in that setting, your patient, I don't know whether that was a patient who actually progressed through teclistamab. Generally, what we see is we just don't get a response in that setting, or response comes slow. But it's one of those things, considering how expensive it is and the probability of its working. It's a discussion to have.
Or if we have a clinical trial, those are the two options which we have if this patient has access to.
They put in there the cevostamab is certainly worth trying if it's available. There are trials starting to look at BCMA bispecific plus cevostamab to see if that would be, again, 2 different target options.
So I think there's just 1.5 minutes left for this session. Uday actually has again asked the role for cevostamab because it's available as a PAP through the GSK now.
Must be through Roche Genentech because they make the cevostamab. GSK will be the belantamab.
So it's the same. So you don't think it's going to do anything more than what we already discussed?
I think the cevostamab, if you can access it, is worth trying. It's a different target. So it's FcRH5.
Yeah. But it usually works better in combinations rather than alone, isn't it?
Yeah. So, the cevostamab has mostly been, they have studied a whole bunch of different combinations. I think we are looking at the TAL3, TEC3 data, and now TAL6 data. I think eventually, most of us are going to be using bispecifics in combination just to get more durable responses with a limited duration therapy.
Thank you for that wonderful discussion and inputs from all the people on the platform. We will go to the second case, and I would invite Dr. Mehak to please present it.
Right. So is the second case visible, sir? PPT of the second.
No, not yet.
Hold on, sir. So now is it visible?
Yes.
Right. So thank you for the inputs on the first case. I've asked the patient to come tomorrow that we have a good discussion today. We'll discuss the options tomorrow with the patient. Coming to the second one, I've named the case when the kidney relapses, but the clone is barely visible. It is a case of MGRS. So let's go to the case, please. 1 second. Right. So, hold on. So we have a 50-year-old gentleman who initially presented to us with proteinuria, periorbital swelling, lower limb edema, with proteinuria of 7.22 grams per day with creatinine of 1.1. Did a renal biopsy. It was suggestive of proliferative MPGN pattern with monoclonal IgG kappa deposits. Anti-Plato-R was negative, and we did bone marrow as well, and it was suggestive of 8 to 9% clonal plasma cells. FISH was negative. There was no M band. Kappa lambda ratio was 1.21. I will go by the timeline how the case was. Right. So he was diagnosed first in November 2024 with proteinuria, like I previously mentioned, of 7.2 gram, creatinine 1.1, MPGN, IgG kappa deposits, and bone marrow disease was not there. Labeled as MGRS, PGNMID. And we went ahead with the patient. We did DARA VRD 4 cycles. And patient responded in April to June 2025, where his proteinuria initially from 7.2 gram came down to 0.7 grams per day. Went ahead with autologous VMT in July 2025. Did not give any maintenance and had a deep response. Proteinuria post-transplant was around 0.3 gram per day. Marrow was negative, MRD negative, PET normal. Again, he presented to us around the month of May with proteinuria gradually increasing to around 9 grams per day. Repeated the myeloma profile. The M spike was 0.17 and kappa lambda ratio of 2.1. Currently, it has increased up to 9 grams. Creatinine is progressively increasing. It is something like RPGN with creatinine of 2.4. M-band 0.14. We did the marrow. It is flow cytometry MRD is positive with 5 into 10 raised to power minus 5, and PET is normal. So currently we have 4 things. There is renal urgency. Like I mentioned, the patient has an RPGN picture, creatinine progressively rising with proteinuria, which was somewhere around 380 milligram to around 10 grams a day. We are assuming it is the same lesion. We have not done a repeat kidney biopsy yet. And apart from that, initially the patient had responded beautifully on DARA VRD. And now what the concern is of DARA reintroduction versus BCMA. So going by the trajectory of the disease, so proteinuria we presented at 7.2. By the time treatment was started, went up to 8.7 grams, improved up to 0.38 post-transplant, gradually rising and currently at 10 grams. Creatinine, like I mentioned, 2.4 milligram per deciliter. M-spike, which was initially negative the first time he was diagnosed, has come up as 0.14. Again, IgG kappa type. Kappa lambda ratio of 2.1, bone marrow flow cytometry positive, and PET normal. So these are the questions I have put forward for the iPro panel, and this is where we are stuck at.
Thank you, Dr. Mehak, for that presentation. Interesting case. And now, of course, we see more and more in our practice because it's picked up. I would again go back to Dr. Rahul Bhargav for his comments on the case and the approach to the therapeutics that we see.
Thank you, sir. So I think the most important thing in this was the 24-hour urine protein immunofixation, which revealed that all that protein was monoclonal in nature. So confirming that there is a plasma cell clone. The biopsy was re-reviewed, but not repeated again to confirm the diagnosis because the plasma cells in the bone marrow as well as the light chains were not super high to confirm or say it is multiple myeloma itself. So patient has been reintroduced with DARA VRD or VCD. patient has started responding within 4 weeks of 4 DARA. The proteinuria from 10 grams have dropped down to 6 grams at this present moment of time. But the idea was to add to this bispecifics or not, because it's definitely a plasma cell clone in the kidneys and the way forward because he's still young. With this, over to Dr. Velu Nair.
Yeah, thank you very much, Rahul. Before I go to the other panelists, I would just like to ask Dr. Mehak, being a proliferative MPGN, did you have any urinary sediments? You talked about proteinuria. So
Yes, sir.
what about any sediments all through?
No, sir. So I went back and reviewed the reports. I could not find anything. Also, IFTA was around 20% at the diagnosis, and that is it. So no
Okay.
urinary sediments. Urine
Okay.
was no hematuria, no urinary sediments,
Thank you.
just proteinuria, and clinical presentation also pedal edema, periorbital swelling. That is how it
Yes.
presented.
With nephrotic range of proteinuria.
Yes, sir.
Thank you.
No nephritic features, just nephrotic. No hypertension, no hematuria.
Thank you very much. So I will go to Kal Vayude now and address the questions for the case. One is, should we think the renal progression should prompt an immediate clone oriented therapy, despite having a very low, paraprotein load as seen by M spike of 0.14 and a PET negative disease and a MRD negative marrow. So the first is that part. So how would you define this in the renal domain and obviously in the hematological domain? And the second question is on the reintroduction of DARA, which I think is that's simpler, but I would like your comments.
Sir, thank you, sir. So, sir, as far as trigger in MGR is concerned, is primarily a organ progression, what we are looking at. So, defined by basically not by the IMG has not defined, but the IKMG has defined the renal criteria, wherein they say that the renal progression of more than 50% rise in proteinuria or more than 1 gram per 24 hours or more than a 25% fall in eGFR. These are considered as renal progression, and renal response is labeled as more than 30% fall in proteinuria or proteinuria absolute values less than 0.5 gram per 24 hours without a more than 25% increase in the eGFR decline. Now, in this patient, though the absolute numbers look small, but the patient had a 26-fold rise from the nadir, plus a doubling of creatinine. So this satisfies both the progression limb several times over and above what has been defined. So definitely, this was a trigger for starting therapy as rightly done by the treating unit. So this fits into renal progression. Now, coming to their second question, which renal and hematological parameters define relapse and response? So primarily, like if we look at the renal, so it's a 24-hour proteinuria or the UPCR, that is urine protein creatinine ratio, and the eGFR slope. But generally, all we have to understand is that renal response lags the hematological response substantially. So it's always good to evaluate hematological simultaneously, if at all, if there is some evidence to start with. Now, what all we can look up to? So mass spec, which is coming up big way, though in India it's still yet to make its stride, but that's one place, mass fix or mass spec. Second is DFLC, as the UK group, they evaluate, they don't look at the ratio, but they also look at the difference of FLC. And third, because clonoSEQ is available in our country at multiple places, so clonoSEQ on the original track sequencing and just not the flow cytometry can actually help us in understanding if the index clonotype is back or not. So those are the hematological parameters which can look at. And the supportive could be serum albumin, BP, urine sediment, as you rightly brought out. So those are few things which the resource constraint setups can do. But yes, this patient definitely had a renal progression, and that's why the patient was appropriately treated. And as far as coming to the reintroduction of daratumumab is concerned, this patient was never refractory to daratumumab because the patient had relapsed almost 10 months after his last dose of daratumumab, which they had received around 12 daratumumab doses. So we call refractoriness, which means progression while on therapy. Now, this patient did not progress while on daratumumab or within 60 days of the last dose. Again, that does not fit in. And also, patient never received any DARA maintenance in this case. So for all these reasons, the treating unit, when they restarted daratumumab, I think that was the ideal combination, ideal drug, which actually showed an initial benefit of bringing down 8.8 to 0.14, a huge benefit. So that's why they reintroduced. And because the current creatinine is 2.4, that's why there's choice of VCD is a good option. So in this patient, DARA VCD would also have been my preference as well, or a DARA VD if the patient would not be able to take cyclophosphamide, but DARA VCD is a good combination. Alternatively, a DARA Pomdex, but DARA VCD would have been my first choice. So I rest my thing there, sir.
And post-transplant role, retrospectively thinking of maintenance with DARA?
Probably I would have given, sir, because the patient had shown a phenomenal response to DARA, the way the proteinuria crashed down to nadir. So probably I would have, like retrospectively, I would have given DARA. But yes, in resource constraint settings, many a time we try to balance out the finances and the versus the ideal therapy. So I probably would have added DARA if there was no resource constraint.
Okay. Now I go to the million-dollar question of the requirement for a second kidney biopsy and the timing for the biopsy. And I will go to Professor Shaji Kumar for this. That in this case, one, would you start therapy notwithstanding the biopsy, and go ahead, plan for the biopsy, because you can't do the biopsy on the same day, you have to plan for it. And if so, do it as early as possible, or is there any chance of not doing a biopsy? The pros and cons. Your comments, please.
Yeah, I think the question is, the biopsy, still might show lesions, and it's always unclear how much of that is, comparing it between different biopsies is always a challenge, because of sometimes can be patchy and you may not get enough glomeruli and all that stuff. So I think a therapeutic trial and improvement clinically if this patient got therapy and did not improve at all, then I think it's reasonable to rebiopsy. But I think we can probably defer biopsy like what was done here. I think the challenge, of course, is, all these therapies that we use for myeloma or plasma cell-directed therapies all have anti-inflammatory activity as well. So with a lot of these PGNMID type lesions, MGRS lesions, it's always challenging to know which part of the therapy actually had the maximum benefit. Is it the anti-inflammatory part of it, or is it the anti-plasma cell part of the therapy? I mean, obviously, this patient is quite sensitive to therapy. I don't know if this is necessarily the impact of clonal depletion versus really the direct effect of the treatment itself in terms of just being an immunosuppressive therapy. The challenge, I think, here is going to be if this patient got 12 months of DARA VCD and a transplant, and it lasted for less than a year, is the DARA VRD, is DARA VCD going to give a durable, stable, long-term response? Only time will tell.
Yes. So just to add to that, going to the clinical side, if you have started the clone-directed therapy and you're getting a reduction in your proteinuria that shows there is a reversible component and is responding, so I don't see any reason to rush for a biopsy. But if the response is suboptimal, or this is second spike, when you said it's getting a response and again starts, obviously you're not on top. You will have to do a biopsy to see what are the reversible, irreversible component, new lesions. So you definitely are fully justified. But having said that, the pros and cons we have discussed. Coming to the chat box, in MGRS, we know one thing. The question is role of maintenance in MGRS. We know that the M component or the paraprotein load is not directly proportional to the organ damage, or it has an amplified effect on the kidney, and the kidney may show much more damage than what you see in terms of a clone, which may not meet any of your definitions for a malignant disease, whether it's a lymphoproliferative or a myeloma or a Waldenstrom, whatever you're talking about. Having said that, so obviously there's something more working here besides just the clone, but we know it does have an effect. So the question here is, I would ask again Professor Shaji for this. After having got a response, is there a role for maintenance, not still having any significant, paraprotein load as in evidenced by an M spike and others? Professor Shaji is there?
I think it's muted. I mean, typically we wouldn't, give maintenance in these kind of low clone settings, especially if this person
Yeah.
was MRD negative, already had a good organ response. Not a scenario where we would typically use maintenance therapy. Now, in retrospect, I don't know if it would have made a difference. It's hard to know. Now, the challenge here is this patient responded so quickly each time that I suspect the impact we're seeing on the kidney is independent of the clone-directed therapy. I think a good component is probably the immunosuppression that is coming with these treatments. And that's what we see with many of these PG and MID, even if there was a recent set of data that was looked at Mayo and a few other institutions. Even in the absence of a demonstrable clone,
Yes.
2/3 of the patients respond to in the presence of a clone, 2/3 of the patient respond to a clonal-directed therapy. In the absence of clone, you still have a clone-directed therapy still works better than a general immunosuppressive therapy. So I guess, we'll have to see how, hopefully the response lasts, and we'll have to just try and take him off therapy at some point and see what happens. And if it comes right back, then it declares itself. Do we continue some kind of a maintenance? And yeah, this is the challenging thing with many of these dangerous small clone situations.
Yeah, we can take some more questions in the chat box. One more is in any role for BiTE?
It comes down to the, if you are trying to eradicate the clone, and if other things haven't worked, I think bispecific antibody is reasonable. The question is, can we do 6 cycles or so of a bispecific antibody, eradicate the clone? And I mean, there's whatever therapy we use, it's going to be difficult to differentiate between what we are attaining through clonal depletion versus just immunosuppression. So I think.
Yes. I just want to make a distinction between a quantitative insult from monoclonal immunoglobulins versus a qualitative insult. What do I mean by that? In our frank myeloma, we see enough of monoclonal immunoglobulins, and we see a certain percentage coming with affected kidneys, that too if they come late to us. Here is actually a small amount and sometimes not even evidence. You can't even pick it up. But we're still linking it up to a benefit which you have very nicely put. It could be a general effect rather than a very specific effect of what we are talking of, anti-clone therapy. So what else could be figuring in this damage to the kidneys in MGRS with such small amounts? But we know that there is a link.
Yeah, there's clearly a link. I mean, the question, what is, kind of a little odd about this situation, right? Compared to most of these small clone diseases, if you look at amyloid, for example, the median time to hematologic relapse is about 6 years after autologous stem cell transplant. Now, what is really concerning with this clone is that it came back within a year of very effective induction therapy and an autologous stem cell transplant that should have kept a myeloma clone away for almost, 4 years plus.
Yes.
And here we have a tiny clone that just didn't stay away. Now, we can see what happens. I think the best thing is to, see the course of the disease. And at some point, you have to stop the therapy and see what happens. If the same thing happens again, the clone comes back, proteinuria comes back, one option would be to treat it more from an immunosuppressive perspective and see if you still get a response in the organ. If that happens, then you might also leave the clone alone. Don't try to eradicate it. But if you see that just the immunosuppressive approach actually does not help, and you really need to get rid of the clone, then you start moving towards something that is more likely to be, effective from a clone eradication perspective, which could be bispecifics or something along those lines.
Okay, so we have another question. This is on, can we say that this was a secondary benefit to dexamethasone? There's a question in the chat box from Colonel Uday, actually.
You never know, right? I think that's the whole thing about
yes,
immunosuppression. I mean, the anti-inflammatory part versus the clone-directed therapy. So, that's what I would, if let's say this completely improves, get back to baseline, you stop therapy and the proteinuria comes back, and I may try something that is typically used for the for many of these proliferative, non-monoclonal gammopathy associated renal proliferative disorders, whether it's any of the other immunosuppressive approaches, and see if that will control the proteinuria and kind of leave the clone aside and see what happens.
So coming to long-term follow-up of such cases, and we know that some of these NGRSs can end up as ESRD, that they can have end-stage renal disease because they have a relentless progression, and it's been seen. And so one is the organ-specific support and treatment, one is the anti-clone treatment. So long-term, suppose you have ended up with an ESRD kidney, and they want to go in for a kidney transplant. What would be your approach for the anti-clone therapy here? To what level would you do before? Because recurrences are known even after a kidney transplant. So what would your advice be for the anti-clone? For how long? Because we don't have an endpoint here. So, in terms of time, in terms of months to how long, till that time you do a renal replacement therapy, go ahead and do a kidney transplant and hope doesn't come back. And to prevent it coming back, how will you do any maintenance long term?
Yeah, I mean, this is an area without a lot of good answers, right? I think if somebody had a clone and had renal lesion that led to ESRD, I mean, I would feel more comfortable getting rid of the clone before I offer a renal transplant to that patient. Again, kidneys are hard to come by, and you don't want to take that risk. Having said that, there are some clones you just won't be able to get rid of, whatever you might do. The question is how much are you willing to push the envelope to try that? And I think a lot of it depends on the patient perspective. This is a young patient. Clearly long-term survival is important. If it was a 70 plus, you might think, or a older patient, maybe just being on dialysis and not doing any particular therapies might be also a reasonable alternative. But it all depends on, the age also needs to be, and the patient preference.
Okay, so I don't see any more
answer. Maybe
questions on the now. Professor Pankaj, please. With your PGI colors, your hand gets blurred.
Yes.
Yes, Professor Pankaj.
Okay, so the first thing is, Dr. Mahek, what was the urine protein electrophoresis at the time of diagnosis? Rahul mentioned that there was a monoclonal component, but how much was albuminuria and how much was Bence-Jones protein?
Sir, at the time of diagnosis, I do not have the records. I tried to trace that. I don't have that time. Later, urine albumin creatinine was around 9. I think I mentioned that.
No. So what I want to know is why we are assuming that it is all because of the monoclonal gammopathy. But I would look at doing a urine protein electrophoresis and immunofixation. That is one. Second, what is the size of the kidneys on ultrasound?
So kidney size they were not contracted. 9.8 around centimeter.
Okay, so they are normal size kidney. They are still normal size kidney. Okay, that is second point. The third thing is, I would at least here in PGI we would like to do a renal biopsy again before proceeding further. That is the third point. The fourth is our upfront treatment is generally DARA VCD. And the reason for that is, as Shaji mentioned, that both inflammatory component and monoclonal component is there. So cyclophosphamide is actually a good drug. So if we find a clone, then we use cyclophosphamide. If we don't find a clone, then many times actually we use rituximab, because somebody had the chat box did mention about the rituximab. So if we find an M clone, then bortezomib cyclophosphamide works well. If you don't find a clone, then sometimes your B cell antibody like rituximab works well. Generally, this is a very fast relapse in this patient. Somebody who had gone and autologous transplant also with an MRD negative status, getting back to the disease, and that too with rapidly progressive renal failure is very, very kind of odd for an MGRS. So I would still prefer doing a kidney biopsy before, going ahead with the treatment.
So, Dr. Pankaj, great comments. I would say every time the urine protein electrophoresis is done from the outside because it was treated somewhere else, the NIT did not show a very high electrophoresis ratios into that. The values were not very high. Second important point in this was the why biopsy was not done, attempted is first the patient preference, and second, because this time the 24-hour urine protein immunofixation has shown a dense band, that is why we said might be a clonal population. Third, we revisited the previous biopsy and looked it again whether there is any B cell clone or not, because we have picked it up previously or some B cell clones where the rituximab have worked previously well in these conditions. And we have got one patient like this, which is like coming as IgG4 disease, and there is no kappa lambda onto that staining. And the fourth important point in this scenario, which was there, was the response to the therapy of DARA VCD, which we have reinstated, and the proteinuria has started coming on because the creatinine this time was really high. And that is why the way we have been thinking about the plasma cell clone and not utilizing the rituximab in these conditions. So these were the points where we have picked it up. And the last point is where we were looking at the MRD. The clone was, there was only 2-3% plasma cells in the bone marrow, and there was an M band was 0.17. So the clone MRD, why I asked question to Shaji, Professor Shaji, was that which tissue we are looking at MRD. I mean, 0.3 gram was a protein when patient responded after autologous. If you would have done the protein immunofixation at that time, if that would have shown some positivity or would have persisted thereafter, we would have given a maintenance therapy. So those were the points. And that is why the tissue at which we are looking at MRD is very, very important.
So Rahul, here actually, like we discussed in the last 10 minutes or so, the size of the clone in MGRS, the jury is still out. Like, we are talking of no evidence to pick up and still linking it because they are benefiting. Now, whether the benefit is because of a general effect or any specific, like the Professor Shaji said, we still don't know. But having said that, I think we don't have to chase that MRD so far so much, but a patient's clone coming back after having achieved, clear-cut MRD after a transplant is what's interesting. So in this case, the disease itself also, for whatever reasons, is more aggressive. He should have got more time after what we achieved. So there are two situations here which are a little odd, but how much they are linked, I don't know. And to that comes the question: I'm not sure whether I know the answer, whether the disease biology and severity, how small the clone is, because you may get it under control early, and the occurrence of MGRS. So is it that a more aggressive disease will have more frequent MGRS or not? But so far, the answer is more often not. So I want Professor Shaji's closing comments on this part of the association of the disease biology of the clone versus the MGRS, the organ, the kidney itself.
Yeah, it's always a challenging thing in these patients. And I think, if you identify a clone, I think trying the clone-directed therapy first and then it makes sense. If you don't identify a clone, certainly, as Pankaj said, B-cell-directed therapy or immunosuppression, and if no response, then go after a clone, do clone-directed therapy, plasma cell-directed therapy. I think it's reasonable. Again, the question is going to be, we still don't fully understand the mechanisms, right? It's not necessarily that there needs to be deposition to actually cause these inflammatory changes within that. So challenge. But one quick thing I just wanted to add to Pankaj's point is these people with heavy proteinuria, you can easily have a normal free light chain and still have immunofixation positive in the urine because whatever they make, they spill out. So.
Thank you so much. So we are bang on time. And I would say, with military precision, it's just going to be 6:30, a few minutes to that. And I would just like to read out Professor Tapan's comment in the chat box. He's saying excellent beginning. And clearly there are more questions than answers. But he said it'll be nice to come back with these cases after a period of time, which we will discuss in the committee and bring it back and talk to you all about it to see what is the progress. So we can always have a progress section in this particular discussions to what we have discussed. and where they are now. Number one. Number two, I think, I think that's the only thing. So I would begin by thanking Dr. Rahul Bhargav and his team, Dr. Mehak Trehan and Team Fortis, for having put up two very challenging cases, which we have really enjoyed discussing. And profound thanks to our international panelist, Professor Shaji Kumar. Early in the morning, he spared his time, and you have really contributed to our many queries today, and to Colonel Vayude for having participated so actively. So with those things, I would close the discussion from my side and hand over the platform back to Colonel Vayude. Thank you. Jai Hind.
Thank you, sir. So thanks a lot to, can we have this in the viewer mode? Yeah. So, so the next session, we are going to have it on 10th of September. Again, same time, 17:30 hours. And that would be moderated by Reena ma'am. So we are going to, so any of these participants who have any interesting cases, you can forward it to either academics@imagesociety.co.in or directly to Dr. Mehak Trehan. She would be compiling the cases. And next month we meet at the same time, 17:30 hours. And with that, I would like to say a big thank you to all those who have participated. At the peak of the session, we had around 82 participants who were listening and who were recording. The complete recordings will be available on Image website for all the members of the Image. So we request you to join membership for Image for taking the benefit of all the academic activities, and they will also be available on the YouTube channel of Image. So you can see all these cases and discussions on our YouTube channel as well. And they would also be coming up. The summary of these cases and what has happened and what was discussed will also be available on our newsletter, which will have a separate section for the iProbe, and which I would request Dr. Mehak to make a summary of this and submit it to the newsletter committee. So with that, thanks a lot to everyone, and Jai Hind.
Bye, sir.
Thank you.
Bye.
Thank you.
Thank you.
Thank you. Thank you, sir.
Thank you.
Thank you, sir.